much. I will talk now briefly about inferior vena cava filters and the use of those. I used the majority of the slides that were given to me by Peter from Dr. Gasparis. Those are old numbers, reflect the number of patients with pulmonary embolism in the United States. And these are also old numbers, but are very important in the sense that we know that patients that present with pulmonary emboli and do not get treatment have a very morbid outcome. But with anticoagulation, appropriately, this is significantly improved. And there's a long history for treating patients with pulmonary emboli or lower extremity DVT with interruption of the inflow vessels, the inferior vena cava or the iliac veins, in these patients that either couldn't get anticoagulation or for some reason were felt that they couldn't tolerate another embolus. And this goes very far back. This then led to development of some percutaneous devices, either a balloon or silicone filters. And then finally we got in 1973 to the current concept, a metal filter that was placed in the inferior vena cava. And I think a pivotal change, and we can get to that later, was really when the endovascular deployment of the filter became a reality. Before, this was always done by a surgical consult. It was very extensive. A cut-down had to be done into the jugular vein and the filter placed then, but this was really the beginning of the current era where the filters are placed through a percutaneous approach. Now, it was early recognized that filters didn't need to stay in forever, and it probably would be beneficial if it could be removed. We had catheters that were connected to a rod that was then placed under the skin in the jugular vein and could then be removed. Or Dr. Amplatz from the University of Minnesota came out with this in the 1980s, a truly retrievable filter with a hook on it, similar to what we are now seeing so commonly. And since then we have now approach or access to multiple filters that can be retrieved but can also be left in place, called either retrievable or optional filters. I put this slide here up only to remind myself to mention the fact that about 90% of all DVT comes from the infradiaphragmatic circulation, about 10% roughly comes from the superior vena cava and arm vessels. And we occasionally are asked to place filters in that location. There has been a very rapid increase in the placement of inferior vena cava filters over the years, and this is a Medicare population in the United States. And you can see that from 1990 to 2008, there has been a doubling in the use of filters in that population, which is the Medicare population. In the same time, the retrieval rate, and this is the period where retrievable filters or optional filters became available, has not followed the same trend. I'm repeating this slide just to remind myself to try to explain why this is. As I mentioned before, filter placement was a difficult procedure before percutaneous approach was developed, and now most of these are placed through a 6, 7, or 8 French introducer seat. Procedure time is about 20 minutes at most, and the patient hardly knows that they have this done. That's probably one reason that filters have become so popular. Also the fact that previously a surgical consult was needed, but now this is really managed by a service department, radiology, which makes it much easier. So not the entire explanation, but part of it. Multiple filters, as I mentioned before, and those are the absolute indication. And you could see here that the grounding for this is not very substantial. And you recognize those indications, which particularly are based on the fact that the patient can't have anticoagulation or they are not fit enough for anticoagulation. Also the relative indications, and this is the brunt of the increase in filter placement, that is prevention or prophylactic placement for major surgeries such as bariatric surgery or in patients with severe trauma. There are data to indicate that patients that undergo bariatric surgery have very high or relatively high rate of developing deep vein thrombosis and pulmonary emboli. And there was a trend, and this I think is reversed now, to place inferior vena cava filters prophylactically in these patients that were planned for bariatric surgery. This has subsequently turned out to probably not be beneficial, and I think this trend has significantly reversed. There are meta-analyses that support, and this goes to the fact that we really have few studies to indicate if filter placement in general is actually helpful, and there are meta-analyses that indicate that is in general not true. That is the fact that they are or the proposition that they are helpful. This is probably the only big randomized study which looked at placing inferior vena cava filter randomizedly into patients with DVT. They were all treated, if I remember correctly, with anticoagulation, 200 patients with filters and 200 patients without filters. And there was a significant reduction in pulmonary emboli rate. The survival probability was not changed at all, so there was no difference in death rate. But if you looked at the recurrence in DVT, there was a significant increase over time in recurrent DVT in the group of patients treated with filters, and those were permanent filters. So, just finally, we are now in an era of retrievable or optional filters. They are meant to be removed. The recommendations are actually to put patients on anticoagulations as soon as possible, even if they have filters in place. This is work by Gasparis, just demonstrating that less than 25% of filters in general are removed, even though they are retrievable. So, as a conclusion, we place, at least in the United States, a large number of filters based on very poor data. Anticoagulation should be given as soon as the indication or contraindication has passed. Retrievable filters should be attempted removed as soon as possible. And then there is no strong or no overall indication